Let's start. Opioid intoxication, DSM-5-TR is the reference for this. Objectives. So after today's talk, we will know better the diagnostic criteria for opioid intoxication, specifier. There is actually one specifier in the DSM-5-TR, ICD-10 codes, associated features of this diagnosis or intoxication, development and course of intoxication, and differential diagnosis. All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to the next session in this series of opioid use disorder and also pain management. So let's start. We'll start with the quick references. So this is drbeen.com. This is another reference. All of these reference links will be present in the description of this video. This is CDC on opioid use disorders. This is American Psychological Association and their definitions for various terms that we'll see today. This is another American Psychiatric Association. This is the link to the DSM-5-TR. That is the book that I'm using. That is the latest revision of the DSM-5 book, and it is called TR Text Revision. So I'll be using this as a reference. Then there are a couple of more definition links over here. With this, let's start. Opioid intoxication, DSM-5-TR is the reference for this one. I have no disclosures. I have no conflict of interests. Objectives. So after today's talk, we will know better the diagnostic criteria for opioid intoxication, specifier. There is actually one specifier in the DSM-5-TR, ICD-10 codes, associated features of this diagnosis or intoxication, development and course of intoxication, and differential diagnosis. So diagnostic criteria. Let me even before that quickly show you. Here is the DSM-5-TR. This is the section opioid intoxication that we are talking about. So the diagnostic criteria, we are talking about intoxication. And just a quick reminder, in the opioid use disorder discussion, we had discussed that if somebody has intoxication or depression or opioid-induced abnormalities, then you will not use the ICD code for opioid use disorder. Instead, these will be merged into the diagnostic codes for whatever disorder you are working with. For example, today we are working with intoxication. So imagine that there is a patient who has intoxication and opioid use disorder. Then you will not use the opioid use disorder ICD-10 codes. Instead, you would use for diagnostic criteria. And I'll show you how to use them. So the opioid intoxication diagnostic criteria, there are 4 parts to it. Number 1, there is a recent use of an opioid. Number 2, clinically significant behavioral or psychological changes. For example, initial euphoria. Euphoria is happiness. Initial euphoria followed by apathy. Apathy is lack of interest in things. Dysphoria, displeasure. Psychomotor agitation. Psychomotor agitation is, it has multiple phases. So first of all, what happens is that the patient within their own mindset, they feel agitated, their thoughts are racing, they become overactive and reactive within their own thinking. Then that results in motor activity or body's responses within the body, so physical responses, which may be, some people start opening and closing their hands, or they would start, tapping their fingers with each other, or they would start tapping their feet. There are various ways that the result would appear physically. So that is a psychomotor agitation or retardation. Retardation is generally looked at a lower IQ, and there is a definition for that. Let me just read it for you. Mild to severe impairment in intellectual ability equivalent to an IQ of 70 to 75 or below, that is accompanied by significant limitation in social, practical, and conceptual skills. So going back here, psychomotor agitation, retardation, impaired judgment that develop during or shortly after opioid use. So one, there was a use. Second, with that use, during that use or shortly after, the psychological and behavioral changes occurred, clinically significant. Then C is pupillary constriction. And we just discussed it before we started recording. Pupillary constriction is a feature of opioid use. However, if you see, pupillary dilatation could occur as well. So criteria C says pupillary constriction or pupillary dilatation due to anoxia from severe overdose. Now what happens is anoxia is absence of oxygen. Hypoxia is reduced oxygen or lack of oxygen. Anoxia is complete absence of oxygen. So we have done this discussion in detail in our past discussions that talks that when the opioids are used, respiratory depression can occur. We actually looked at the wiring of the system as well within our brain for how the respiratory depression occurs. We also looked at how the sensory system, the chemical system, doesn't respond correctly when the opioids are being used. And so our respiratory system goes into a depression. So when there is respiratory depression deep enough that there is lack of oxygen or no oxygen to the brain tissue, that anoxia can cause brain tissue damage, which can then result in lack of control on pupillary muscles, and pupillary dilatation would occur. So the presence of pupillary dilatation is not a good prognostic sign. So pupillary constriction or pupillary dilatation due to anoxia from severe disease. Now, what are the additional things? So going back to the criteria number C, pupillary constriction or pupillary dilatation due to anoxia from severe overdose and or more of the following, one or more of the following signs or symptoms: drowsiness or coma. So these three, one or more: drowsiness or coma, slurred speech, impairment in attention or memory. So this is the criteria C. Criteria D, the sign or symptoms that you're observing, may that be psychomotor agitation, may that be with pupillary constriction, maybe there is some drowsiness. Let's say these are what you're observing. The signs or symptoms are not attributable to another medical condition and are not better explained by another mental disorder, including intoxication with another substance. So you have to rule out the other possibilities to then focus back here and say this is opioid intoxication. Now specifier, it has one specifier. That one specifier is, so we're talking about intoxication and diagnosing the intoxication. There is one specifier that you can add to patient's history, and that is with perceptual disturbance. This may be that with perceptual disturbance or without perceptual disturbance. So if you see perceptual disturbances, you can add that as a specifier. So what is this specifier? So imagine that we are looking at the previous state here, and you've seen that recent use disorder, recent opioid use. Then the patient has, let's say they are in dysphoria and apathy state, and there some psychomotor agitation is present. Let's say pinpoint pupils are present. They're a little drowsy. They're becoming drowsy. And you cannot see that any other reason is possible for this situation. So the specifier is with perceptual disturbances. What is that? This specifier may be noted in the rare instance in which hallucination with intact reality testing or auditory, visual, or tactile illusion occur in the absence of a delirium. So hallucination or illusions can occur in the absence of delirium. And please remember that this specifier will be rare. It's not common during the opioid intoxication for the patient to have hallucinations or illusions because they themselves are getting deeper in the intoxicated state. But what are these? So quick difference between hallucination and illusion. So sensory perceptions based on reality or not. In case of illusion, what happens is that you have sensory input coming in, but there is a misinterpretation of that sensory input. And it is not necessary that that misinterpretation occurs only in these patients, although they would start having sensory illusions or various kinds of illusion. An example of illusion for all of us without any opioid intoxication is, for example, when we look at train tracks, they seem to be merging at a distance. They appear to merge at a distance. Now, the reality is that they don't merge. They are separated from each other. But they appear to us as if they have merged. This is an illusion. This is a misinterpretation of reality. The input is coming from the reality. We have misinterpreted that. On the other hand, hallucination does not have sensory input coming from reality, but the patient is still feeling something which seems very close to reality, or they're perceiving something. So hallucination is a false sensory perception that has a compelling sense of reality, despite the absence of an external stimulus. It may affect any of the senses, but auditory hallucinations, visual hallucinations are most common. Right? So auditory hallucinations are to hear some sounds or voices or hear someone talk, while in reality there is nobody there. So it is important for hallucination to see that this is the presence of a sensory signal when in reality there is none. So hallucinations can occur in intoxication. Similarly, illusions can occur in intoxication as well. A false sensory perception, illusion of the senses, such as visual illusion, result from misinterpretation of sensory stimuli. For example, parallel railroad tracks appear to meet in distance. And then, as you saw in the criteria, the third part was absence of deliriums. So what is delirium? A disturbed mental state in which attention cannot be sustained. So there are three parts to delirium. Number one, attention cannot be sustained. Number two, environment is misperceived. And number three, the stream of thought is disordered. Although if you look at the DSM-5 TR, this diagnostic manual, there is a complete diagnostic criteria for delirium. So this is really from the American Psychiatric Association's definition. It is not the diagnostic criteria that I'm presenting here. The definition of delirium is a disturbed mental state in which attention cannot be sustained. So first part. Environment is misperceived. Second part. For example, I have this mic over here, and imagine if I misperceive that as a snake. And then the stream of thought is disordered. Three parts. The individual may experience changes in cognition, which can include disorientation, memory impairment, or disturbance in language, perceptual disturbances, hallucinations, illusions, and misinterpretation of sounds or sights. So this part, the delirium, is absent. Illusion and hallucination may rarely be present. continuing. Now, how do you code this? It's actually very simple. So opioid intoxication, the ICD-10 CM code depends on, so there are two things that you have to care for. Number one, is there a comorbid opioid use disorder? Does this patient, does this person have opioid use disorder plus they are intoxicated? Or they didn't have an opioid use disorder, but they are intoxicated. Somebody gave them opioid for the first time, or they took a lot of opioid the first time and they got intoxicated or accidental, whichever way it is, they are not in the opioid use disorder, but they are intoxicated. So that is first, whether or not they have disorder. Second part is whether or not they have perceptual disturbances. So how do you code them? If you see here, there are two tables. The table 1 is without the perceptual disturbances. So there is intoxication, but there is no perceptual disturbance. Second table is there is intoxication with perceptual disturbance. So let's look at the first one first. This is the intoxication without the perceptual disturbance. Now the question is, do they have any opioid use disorder as well? So there are going to be three states. Either they have a mild use disorder, or they may have moderate or severe use disorder, opioid use disorder, as a comorbidity, or they will not have it. So how do we code it? If you look here, F11.120, this character number 4, I have made this one bold. This fourth character or letter will define the use disorder. If it is 1, that means this is opioid intoxication with mild opioid use disorder. If it is 2, for example, F11.220, the 2 over here at the fourth letter, or the fourth letter 2, is for moderate to severe comorbid opioid use disorder being present. In this case, you will not actually put the diagnostic code for use disorders. You will not use them. You would use this, but 1 or 2 will be used for the severity. And if the patient does not have use disorder, let's say they got intoxicated without use disorder, then you will put a 9 at the letter number 4, or the fourth letter. So F11.920 means opioid intoxication without perceptual disturbances and without opioid use disorder. Now, if this is with perceptual disturbances, then once again, if you see here, the basic is F11 point, then the letter for use disorder, present or not, and if present, what severity? 22. So F11.122, this 1 will mean mild opioid use disorder present with intoxication with perceptual disturbances. F11.222 will mean opioid intoxication present, perceptual disturbances are present, and the severity of opioid use disorder comorbidity is moderate to severe. And finally, if it is 9, F11.922, then no comorbid opioid use disorder is present. It's just the intoxication with perceptual disturbances. So I hope this is clear. Then are the diagnostic features. This is really just a repeat of the criteria that we saw in C and D points. So the essential feature of intoxication is the presence of clinically significant problematic behavioral or psychological changes. As we discussed before, euphoria first, then apathy, dysphoria, psychomotor agitation, retardation, impaired judgment, that develop during or shortly after the use. So that is criteria A and B. Criteria C, intoxication is accompanied by pupillary constriction or dilatation, as we discussed before, and the drowsiness, slurred speech, impairment in attention or memory. That is criteria C. The drowsiness may progress to coma. So patient might actually become comatose after the drowsiness. Individuals with opioid intoxication may demonstrate inattention to the environment. So they're sitting in there, but they're not paying attention to their surroundings, even to the point of ignoring potentially harmful events. The signs or symptoms of opioid intoxication must not be attributable to another medical condition and are not better explained by another mental disorder. So that was the criteria D. Now, diagnostic features, an important thing to keep in mind that up to 2009, opioid overdoses were mainly due to prescribed opioids. Up to 2009. Then in 2010 and onwards, heroin became the dominant cause for intoxication. So heroin began a sharp rise. Then additionally, since 2015, so in addition to heroin, since 2015, fatal overdose due to synthetic opioids other than methadone, generally fentanyl, have outnumbered overdose due to prescribed opioids. So nowadays, if somebody is in overdose, there can be a greater suspicion to non-prescribed opioid use, especially intoxication. Associated features. So intoxication can include decrease in respiratory rate, which we have done this discussion before as well. Even if somebody is not intoxicated, opioids tend to cause reduction in respiratory rate. So of course, if they are intoxicated, there will be decrease in respiratory rate and reduced blood pressure and mild hypothermia. And we have looked at these mechanisms in the first few lectures. The duration of opioid intoxication can vary as a function of pharmacokinetics of the opioid ingested. So this is when one of the participants said earlier that when we are trying to counter the intoxication, it will depend upon the half-life of the ingested opioid to see how long we need to counter. So same way, intoxication's own duration will vary between various kinds of drugs that may have been taken. So opioid intoxication duration can vary as a function of pharmacokinetics of the opioid ingested. Opioid intoxication may result in fatal or non-fatal opioid overdose. So opioid use, from there intoxication, if it happens, then intoxication may or may not become overdose, which the overdose may or may not be fatal. Opioid overdose is characterized by unconsciousness, respiratory depression, and pinpoint pupils. Fatal opioid overdose have increased exponentially in the US since 1999. Now, development and course. How does this intoxication develop? What is the course of it? So opioid intoxication can occur in an individual who is opioid naive. Why do we need to know that what is their own state? The development and the course or the progress of intoxication will be different if somebody is seeing or is intoxicated for the first time and has not used them before. So it can occur in individuals who are opioid naive, or those who have used opioids sporadically, or those who have physical dependence on opioids. The dose of opioid consumed relative to the likelihood of experiencing opioid intoxication will vary as a function of the status and history of the individual's opioid exposure or tolerance. So the same dose will not produce similar intoxication outcomes if the individuals who are receiving it have different levels of tolerance because of their use or exposure to opioids. Individuals often report that the qualitative pleasurable experience of opioid intoxication diminishes after repeated use of an opioid. And we did this discussion in detail as well with the mechanisms that how does this happen. Differential diagnosis. So this situation, can this happen with other drugs as well? Or what else can cause this? So a couple of things to keep in mind. One is intoxication by other substances, alcohol intoxication, and sedative hypnotics intoxication can cause a clinical picture that resembles opioid intoxication. So imagine that you have received a patient who has these features that you suspect it is opioid intoxication. However, they could have the same features, same clinical presentation because of alcohol intoxication or sedative hypnotics. So diagnosis of alcohol or sedative hypnotic intoxication can usually be made based on the absence of pupillary constriction or the lack of response to a naloxone challenge. So you observe them and you see, do they have pupillary constriction or not? And secondly, do they respond to naloxone challenge or not? Although there can be exceptions. So I'm going to read an exception. And we have already talked about intoxication and pupillary dilatation as well. So in some cases, intoxication may be due both to opioid and alcohol or other sedatives. In these cases, naloxone administration will not reverse all of the sedative effect. The word all is very important here. There will be some improvement, but not all the effects will be reversed. That may mean that there is additional alcohol or sedative hypnotics present in the system as well. Now, we are still not done. While response to administration of naloxone can support the diagnosis of opioid intoxication, non-response. So you have a patient who you suspect is opioid intoxicated, you gave them naloxone, they started reversing, and you said, well, this was opioid intoxication. However, somebody who did not reverse, are you going to now think it is alcohol or sedative hypnotics? So here out one more set of features. Non-response may be due to the co-ingestion of an opioid with another drug, for example, benzodiazepine or alcohol, or to ingestion of higher dose of and or higher potency opioid, for example, fentanyl. So non-response to naloxone is not an automatic. There may be alcohol or hypnotic sedatives. It is possible that the opioid dose itself is high or potency is high, and naloxone is not able to counter it that effectively. So please, this differential diagnosis is important to keep in mind. So you look at a patient who has pinpoint pupils, who are becoming drowsy, has this euphoria or dysphoria or psychomotor agitation. So you see all of those A, B, C, D criteria, and you administer naloxone and you don't see a response. That doesn't automatically mean that it is not opioid intoxication. And I have just presented these cases to you. Differential diagnosis can also be looked at from opioid induced mental disorders. We have to differentiate from there as well. We're talking about opioid induced mental disorder now, and its differentiation from intoxication. Opioid intoxication is distinguished from opioid induced mental disorders, for example, opioid induced depressive disorder, with onset during intoxication. It can start during intoxication, but then it would have its own course. And you have to separate them to be able to say, is the patient intoxicated right now, or are they in opioid induced mental disorder? Because the symptom, for example, depressed mood, in the latter, that is the opioid depressive disorder, opioid induced, in the latter disorder are in excess of those usually associated with opioid intoxication. And here the term usually or all, as we read before as well, these are directly from the DSM-5 TR. So it is not my editorialization. This is how they have written it. So those usually associated with opioid intoxication predominate in the clinical presentation and are severe enough to warrant clinical attention. So I think my interjections kind of diluted the sentence. I'm going to read it once more. This is the last part. Opioid intoxication is distinguished from opioid-induced mental disorders, for example, opioid-induced depressive disorder with onset during intoxication, because the symptoms, for example, depressed mood, in the latter, disorders are in excess of those usually associated with the opioid intoxication, predominate in the clinical presentation, and are severe enough to warrant clinical attention. So you have to separate them. So in the differential diagnosis, you have to see intoxication by other substances, and you have to see opioid-induced mental disorder, because the clinical pictures will be overlapping, but as we saw, there are differences. So this is the discussion. Thank you very much for listening in.